The following podcast is part of a certified educational activity titled Visualizing the Role of Neuroinflammation in the Pathophysiology and Management of Alzheimer's Disease. Access the entire activity and complete the post-test at peerview.com/AFJ860. Downloadable practice aids are also available.
Hello, everyone. My name is Eric Music. I'm a professor of neurology at Washington University School of Medicine in St. Louis, Missouri. And I'll be talking to you today about visualizing the role of neuroinflammation in the pathophysiology and management of Alzheimer's disease. Our goals for today are to augment your knowledge about the role of neuroinflammation in the pathogenesis of Alzheimer's disease and to help you understand the current emerging diagnostic tools to optimize the diagnosis of Alzheimer's disease early in the course of the disease. We hope to provide guidance on the latest evidence supporting the use of new and emerging therapeutic options for the management of patients with Alzheimer's disease. So we know that neuroinflammation plays a role in the pathogenesis and the progression of Alzheimer's disease. And so neuroinflammation in general is the brain's immune response to any kind of damage or injury or infection in the central nervous system. Immune cells produce a variety of inflammatory mediators, including cytokines, chemokines, prostaglandins, free radicals, complement proteins, and adhesion molecules that can recruit other cells from the periphery or from other parts of the brain. There's two sorts of immune activation. There's the innate immune response, which are cells that are kind of resident in the brain. And there's the adaptive immune response, which primarily consists of B cells and T cells that are primarily in the periphery, but then can move into the brain. We're going to be talking primarily today about the innate immune response. And the innate immune cells of the brain that we'll be talking about today are microglia and astrocytes. These are the two most abundant. And these are the cells that reside in the brain that seem to be involved in neuroinflammation. So in general, microglia and astrocytes play normal homeostatic roles in the brain. They're there for a reason. Under normal resting conditions, they have a lot of functions. And so these homeostatic glial cells do things like support neuronal metabolism, control synaptic function, regulate neurotransmitters in the brain. And actually, microglia, which are much like macrophages of the brain, have a variety of functions under physiologic conditions, including immune surveillance, trophic support, so they release growth factors that help neurons survive. They can remove pathogens. They can remove dead cells as they die, kind of keep the place clean. They can prune synapses. So microglia can phagocytose damaged synapses or dysfunctional synapses and remove them and promote repair of synaptic connections. And they can also play a role in general neuronal plasticity. Astrocytes are really critical for the brain. Your brain cannot function without astrocytes. And they do a number of things, including interact with blood vessels to help form and control the blood-brain barrier. And they play a key role in fluid dynamics in the brain. They can regulate cerebral blood flow through their interaction with blood vessels. And they play really critical roles at the synapse. So they are a key component of all synapses as the astrocyte. And they control neurotransmitter uptake and recycling to maintain proper neurotransmitter levels. They're very critical for neuronal metabolism, so they help make lactate, which is used by neurons for energy metabolism. And they help to maintain synaptic homeostasis, control synaptic strength and firing, and provide trophic support for neurons and regulate oxidative stress and a variety of other things. So if there's an injury to the brain, if there's an infection, or if there's the accumulation of aberrant misfolded proteins, as we see in neurodegenerative diseases, this can trigger the inflammatory response in these cells. And when that happens, they become reactive, they change their morphology, and they actually tend to lose their homeostatic functions. And they take on a role involved in inflammation. And so in the case of activated or reactive microglia, they tend to lose some of these homeostatic functions, they reduce secretion of neurotrophic factors, and they start to produce more pro-inflammatory molecules like cytokines, IL-1 beta, TNF-alpha. There's often activation of the NF-kappa B pathway. They can produce reactive molecules like reactive oxygen species, nitric oxide, interferons. They can release complement proteins, which can facilitate the aberrant synaptic pruning. So they normally are pruning synapses, but in the case of inflammation, sometimes this becomes dysregulated and healthy synapses can be pruned and you can have synaptic loss. And activated microglia can actually also interact with the adaptive immune system, so they can release factors that will then recruit peripheral immune cells and bring them in that can also participate in this inflammatory response. Astrocytes, it's much the same. They can lose some of their homeostatic functions. One could argue that astrocytes have more homeostatic function than microglia, and so this loss of homeostatic function actually probably plays a role in these diseases. But they can also produce pro-inflammatory cytokines. They change morphology and upregulate a protein called GFAP, which is a marker of reactive astrocytes in the brain. And when they're doing all these things and changing morphology, sometimes this may lead to disrupted blood-brain barrier function of these cells. So there's both a loss of physiologic function that's detrimental, as well as this gain of inflammatory function that can potentially damage surrounding neurons in the brain. So chronic microglial activation and neuroinflammation, we think that this facilitates pathophysiology of Alzheimer's disease. Aggregated amyloid can actually induce local microglia reactivity. Amyloid and tau can also damage neurons, and these damaged neurons can release damage-associated molecular patterns, or DAMPs, that can help activate the positive feedback loop in which neuronal injury and protein misfolding is causing glial activation, and these cells can then produce more cytokines that contribute to the neurodegenerative process, and so on and so forth. Methodologies like single-cell RNA-seq have allowed us to look at microglia and astrocytes in a lot more detail, and we've found that the microglia in particular take on this unique phenotype, which we've called disease-associated microglial phenotype, or DAM. And these DAM cells are microglia that express genes that are somewhat unique to the neurodegenerative process. I won't say they're entirely unique to Alzheimer's disease, because you can see them in other degenerative diseases, but they are different than you see in diseases like multiple sclerosis or encephalitis or meningitis. And so one of the main genes that's been discovered that's really critical in this process is TREM2. And TREM2 is a receptor that's expressed on macrophages and microglia almost exclusively. It turns out several of the genes that are risk factors for Alzheimer's disease are expressed almost exclusively in microglia. So this microglial response is really important in the disease process. So these DAM microglia, they express a kind of a unique molecular signature with proteins such as CLEC7A, CST7, SPP1. They also express apolipoprotein E, or ApoE, which is the most important genetic risk factor for sporadic Alzheimer's disease. So we think that these damage-associated microglia can have a protective role early in the course of the disease, that they may phagocytose A-beta and keep the plaques in check. However, as the disease progresses and the inflammation gets worse, they can take on a degenerative role by producing cytokines and through activation of the NLRP3 inflammasome, which we'll talk about in a moment. And so the role of these cells in Alzheimer's disease is complex in that it matters what stage of the disease you're in, whether or not this inflammatory response is good or bad. And understanding this biology is really critical. So one of the inflammatory responses that seems to be detrimental in the brain that's driven by microglia is this thing called the NLRP3 inflammasome response. So in the setting of amyloid pathology, or when there's amyloid plaques around, it can activate certain receptors on the surface of microglia and other cells that can then lead to activations to certain molecular pathways, such as the NF-kappa B pathway, which is a general inflammatory pathway, in which this gene is expressed, which then leads to the production of these things called inflammasomes, which are these micromolecular structures that are formed inside and then released out into the extracellular space. But these inflammasomes highly increase the inflammatory response in that area. They can cause damage to local neurons, and they can also seem to stimulate the production of amyloid beta, potentially through the upregulation of enzymes that cleave the amyloid precursor protein, such as beta secretase or BASE. And so this whole thing kind of forms a positive feedback loop in which amyloid beta causes inflammation and causes the inflammasome to be upregulated, and then that can then cause more amyloid beta to be produced. And there's several papers showing that if you delete this NLRP3 gene in mice, that it prevents amyloid plaque formation and also reduces tau pathology in mice. So it seems as though this inflammasome response plays a key role sort of as an intermediary in the disease process. So another thing that the innate immune response can do that needs to be considered is it can interact with the adaptive immune response. So the brain can interact with the periphery. It used to be thought that the brain was immune privileged, meaning that outside immune cells in the blood and in other parts of the body couldn't get into the brain. But now we know it's not that simple. So There are some studies recently from several groups showing that in mouse models of Alzheimer's disease, either amyloid models or tau models, that T cells can enter the brain in the setting of neurodegeneration and actually contribute to neurodegeneration. And if you eliminate these T cells using drugs that are available for humans, that can have a protective response. There's a lot of unknowns, but a lot of excitement about how inflammation in the immune system can be modulated to affect Alzheimer's disease.
Let's learn more about the role of microglia and neuroinflammation in the pathogenesis and progression of Alzheimer's disease.
Alzheimer's disease is characterized by the accumulation of amyloid beta plaques and hyperphosphorylated tau protein in the brain, leading to the formation of neurofibrillary tangles that aggregate inside the neuron and induce cell death. Neuroinflammatory reactions in the brain are a key factor in the progression of Alzheimer's disease, and microglia and astrocytes are the primary cells involved in the neuroinflammatory response. Microglia are the resident immune cells in the central nervous system. They become activated when they are exposed to a threat to the CNS, such as amyloid beta, which they identify with damage-associated molecular pattern, or DAMP, sensing receptors, including toll-like receptors, scavenger receptors like CD36, RAGE, TREM2, and others. Early in AD pathogenesis, the mounted immune response by activated microglia exerts positive effects like the phagocytosis of amyloid beta. However, prolonged activation of the immune response results in reactive microglia and astrocytes that lose their homeostatic balance and release excessive amounts of toxic products, including reactive oxygen species, nitric oxide, pro-inflammatory cytokines such as IL-1 beta, IL-8, and tumor necrosis factor, which damage the blood-brain barrier and induce tau accumulation and neuronal death. Additionally, exposure to amyloid beta can activate the nuclear factor kappa B pathway in microglia. This leads to the assembly of the NLRP3 inflammasome, which initiates a molecular signaling pathway that facilitates amyloid beta aggregation and neuronal damage. Systemic inflammation can also promote Alzheimer's disease progression by triggering the recruitment of peripheral immune cells into brain tissue through the weakened blood-brain barrier, where they can exacerbate neuronal damage by creating an inflammatory cytokine storm that further affects glial cell function and damages neurons.
The next module will be optimizing the diagnosis of AD with current and emerging tools. So I'm going to switch gears and talk a bit about how in the clinic we evaluate patients and potentially make them aware of and available for different sort of therapies for Alzheimer's, because we now have some disease-modifying therapies that are available in the clinic. So some of the screening tools that we use are that commonly used in different clinics around the country, things like the MoCA, the Montreal Cognitive Assessment, the Mini Mental Status Examination, or the Mini-Cog. These are kind of general screening tools. And the MoCA has a little bit more emphasis on short-term memory and probably is a little bit more sensitive than, say, the MMSE, but MMSE is kind of the gold standard used in a lot of clinical trials as well. There's functional screening tools, so you want to also know, has there been changes in these people's function in their life and in the community? These are usually administered not to the patient only, but also to a care partner, this collateral source, which is very important. Patients don't always have great insight into their own memory problems, and you really need a collateral source to confirm some of this information. And then we have behavioral screening tools that look for things like neuropsychiatric symptoms like visual hallucinations that might suggest dementia with Lewy bodies, or behavioral changes, lack of empathy or disinhibition that might suggest frontotemporal dementia, or things like depression that might cause a pseudodementia. In our clinic, we use something called the Clinical Dementia Rating, the CDR. This is really a research tool. It's used in almost all of the major research studies, but we use it as a kind of a structure for our interview because it evaluates 6 different domains: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. And by evaluating each of these things, it allows us in our clinic really to get a good feel for where this person stands in sort of in the degree of memory loss and impairment that they may have. And so when we evaluate each of these things, we ask questions about, repetition, forgetfulness, misplacing items, forgetting appointments, things like that. For memory is really a critical one. And you can see there's various other things we ask about. Can they pay their bills? Can they drive places on their own? Can they shop for groceries independently? Can they still, volunteer and go out with friends, do things like this? Can they bathe on their own? Do they need to be reminded to change their clothes? And all of this goes into a kind of a matrix that we score these patients on. And just so you have some idea, the patients that we're really looking for these new treatments, the very mild patients, they fall into these CDR 0.5 to CDR 1 range. We really prefer 0.5, which is very mild. It correlates with mild cognitive impairment. So these MCI patients, they don't have dementia. They can still function independently, but there have been some changes in their function that are apparent to their collateral source. And, part of the process that's really growing in importance is the biomarkers, because we can't always tell just by interviewing a patient and their family if they have Alzheimer's disease or not. So the biomarkers are really important, and there's a growing number of biomarkers that are kind of in the research realm, but in the clinical practice, we still have a relatively restricted number that essentially look at amyloid pathology. Amyloid beta levels in the cerebrospinal fluid and plasma change very early, probably 10 to 20 years before the onset of symptoms. So amyloid PET, you can see at least a decade before they have symptoms, becomes positive. So they have plaques in their brain. You can see with amyloid PET. You can also detect these by looking for things like the amyloid beta ratio or the phospho-tau species in spinal fluid or now in plasma. And once the plaques have been there for a few years, you start to see tau pathology occurring. So aggregated tau can really only be seen with tau PET at this point, which is not clinically available in most places, but is used in research. And once you start to develop this aggregated tau pathology, you're on the road towards symptoms. So usually that's very close within a couple years of the onset of symptoms. Then your MRI is starting to show atrophy. You're starting to become more obviously impaired. Markers of neurodegeneration like neurofilament light chain begin to go up in the spinal fluid. And then you start to see this decline in cognition. So the point is, these biomarkers are positive years before the onset of symptoms. And so we're not going to miss patients just because they're too early in the course. If the patient has symptoms, they've already had plaques for at least 10 years. So the amyloid markers should be positive in those patients. And so, these are the updated criteria for diagnosing Alzheimer's disease with biomarkers. You may have heard of the ATN criteria, or amyloid, tau, and neurodegeneration. This has been updated now, so there's different levels of biomarkers. The primary biomarker are amyloid, as I mentioned. So amyloid PET being kind of our go-to one, but you can also look at A-beta 42 to 40 ratio, as well as these p-tau species in the spinal fluid, that these actually, even though they're tau species, they go up when people have plaques. And so these ratios of these different amyloid and tau species are very sensitive for detecting plaques in the spinal fluid if you don't have access to amyloid PET. As the disease progresses, there's these core 2 biomarkers that look at tau pathology. So the most available one of these is tau PET. Like I said, not usually available in clinical practice at this point, but probably will be in the future. There are also some emerging plasma and fluid biomarkers for different tau species like this MTBR tau, which really shows you aggregated tau as opposed to these other ones that are more plaque related. And then biomarkers of neurodegeneration like neurofilament light chain or FDG PET imaging or MRI volumetrics that show you atrophy of the brain. There's inflammatory biomarkers now like GFAP, which is an astrocyte biomarker that I mentioned before that show astrocyte activation. Correlates really closely with amyloid plaques. And then there's vascular biomarkers where you can get MRI and look to see if people have vascular disease of the brain. And now alpha-synuclein. Synuclein seems to play a role in about half of Alzheimer's cases. And so these are not really used often in clinical practice, but in the future they probably will be. So we pretty much stick to amyloid biomarkers at this point. And then the emerging exciting ones are these plasma tests. Some of these, particularly the ones that look at phospho-tau 217, they're highly accurate. So some of these are really as accurate as CSF at this point, but they're not currently FDA approved. Some of them are much better than others. So I think that these tests need to be kind of standardized a bit, but I envision that these plasma tests will become very widely used in the near future. So what's new? What else is coming for biomarkers? There's a number of digital biomarkers that try to pick up behavioral changes and things like wearable headbands at home that can do EEG assessment to monitor sleep changes that may detect dementia early, speech patterns, eye movement abnormalities. So the whole world of digital analysis and AI is coming to look at these things. So module 3, we're going to switch gears again and talk about targeted approaches for Alzheimer's disease, a closer look at the latest evidence. So there are many clinical trials ongoing. Most of them are still in phase 1 and phase 2, But as you can see, they cover a lot of different processes and targets. Obviously, amyloid and tau are very high. We already have amyloid drugs in the clinic that we are using now. All these other ones are still in trials. You can see inflammation and immunity. There's a number of drugs in phase 2, a couple in phase 3, but there's really a potpourri of molecular targets that are being assessed in Alzheimer's disease. And I think that's terrific because we already have amyloid drugs. Potentially, you could add some of these that have different targets as adjunct therapies, and hopefully they'll work in concert with one another. So I mentioned that we have anti-amyloid monoclonal antibodies in the clinic already. These are FDA approved, the first disease-modifying treatments for Alzheimer's disease. There are 2 that are currently in clinical use and fully FDA approved, and lecanemab and donanemab, but they both target amyloid beta. Lecanemab targets protofibrils, which are soluble form of A beta, these sort of oligomeric species. But lecanemab also targets the plaque and actually removes plaques very effectively. Donanemab targets a different moiety, the pyroglutamate modified amyloid beta, which is found almost exclusively in the plaques. So both drugs, lecanemab and donanemab, can remove plaques pretty effectively within an 18-month period and usually within about a year. This is amyloid PET data showing that the amyloid PET signal returns essentially to normal in both cases by about 18 months of use in most of the patients. So do they work? So in both clinical trials, large phase 3 clinical trials, both lecanemab and donanemab met their primary endpoint and their secondary endpoints as well. And the primary endpoint in both cases was the clinical dementia sum of boxes, the CDR scale I mentioned earlier. In both cases, these drugs slow the course of progression of the first 18 months of treatment by about 27 to 29%, so about 30%. If you look at some of the secondary endpoints, there was a little bigger effect, up to about 40% slowing. So this does not cure the disease. Even the patients on the drug still progress, but they seem to progress slower. But our data set is relatively limited. We only have 18 months of data, so we don't know where this is going to go beyond that. There's some data that if you treat earlier, it actually can get more like a 50 or 60% slowing, that we can get there and have a really big impact on the disease. So there's certainly space for new drugs and to optimize these drugs as well. One of the big problems with these drugs is this thing called ARIA, amyloid-related imaging abnormality. So this comes in 2 flavors. There's ARIA-E, which is edema, shown here on the left, and then there's ARIA-H, which are these microhemorrhages, shown on the right. Both are pretty common in patients that take these drugs. Somewhere between 12 and 50% of patients will get these, depending on their ApoE4 status. In most patients, these are asymptomatic findings. We see it on MRI and then have to adjust the dose or stop the drug. Rarely, though, these can be severe. Patients can have symptoms about 2 to 3% of the time with lecanemab and maybe 5 to 6% of the time with donanemab. And there have been some cases who have had hemorrhage or death from ARIA. So those are rare, less than 1 in 1,000, but they are certainly concerns, and we take this very seriously. So as you can see from this figure, there are a lot of different potential targets for inflammation. So we don't know which of these are the best yet. I mentioned this one, NLRP3 inflammasome, as being important. DAM microglia are shown here. The complement cascade, these are proteins that seem to play a role in inflammation and synaptic pruning. There's a lot of drugs targeting TREM2, various interleukins and other cytokines. I think the issue is that the time in the course of the disease when you treat may vary. So some of these drugs may have a protective effect, later in the course, but they may have a worsening effect early in the course because the role of the immune system may vary over the course of the disease. For instance, if you have a more robust inflammatory response in this preclinical phase, you may prevent the formation of amyloid plaques in the first place and actually be protected. But once you have plaques and you have degeneration and there's a lot of inflammation going on, having more inflammation at that point is just going to cause more damage. So there are points in the disease where you maybe want to suppress the immune system, and there's points in the disease maybe early on where you'd maybe want to ramp up the immune response. And so we need to figure that out. So here's some of the evidence for some of these different immune modulating treatments. So BCG is an old vaccine that's been used for years. There's a cancer trial that showed that people that were getting this to try to stimulate immune response against bladder cancer seemed to have a reduction in their Alzheimer's disease. The same holds true for these GLP-1 agonists that we'll talk about, liraglutide and semaglutide. These are drugs that are essentially used for weight loss and for diabetes, but they noticed in several of these studies that patients that took these drugs seemed to have less atrophy of the brain, they had better cognitive function, and suggested that maybe these drugs have an effect on Alzheimer's disease. And then there's other more kind of generic drugs targeting this one, masitinib, which targets c-KIT, which is involved in immune responses. And it seemed as though patients that took this drug had slower progression of their dementia. Things like montelukast that inhibits leukotriene receptors. Again, patients on this drug in small trials seem to have some positive benefit. NF-kappa B, I mentioned that pathway earlier. There's animal data suggesting that inhibiting that pathway can have protective effects. So I'm going to talk for a minute about these GLP-1 drugs, such as semaglutide and liraglutide. These are very hot drugs for weight loss and diabetes, and they've been shown to reduce risk of other diseases such as stroke and heart disease in patients, mainly by improving their metabolic health. And they really do a lot of different things. Some of these are direct effects. Some of them are indirect effects related to changing, food intake and whatnot. But in the brain, they seem to lower amyloid beta and tau in mouse models. They have some positive neurotrophic effects that can increase growth factors that are protective. They seem to improve mitochondrial function and general metabolic function. They seem to lower inflammation, potentially by improving the insulin signaling pathway in the brain, which there's, this data that insulin signaling in the brain of Alzheimer's patients is abnormal. So it's an interesting pathway. So these drugs may have direct effect on Alzheimer's. It may be an indirect effect, but the thought is if they're already being used, they all have a lot of other positive effects. It would be great if they also had some impact on Alzheimer's disease. There is this observational data from humans that people that take these drugs seem to have lower risk of dementia. So there's two trials, EVOKE and EVOKE Plus, using semaglutide in patients with early Alzheimer's disease. They're recruiting patients that are almost identical to the ones that were recruited for the anti-amyloid drugs. So these are patients with very mild symptoms, a CDR score of 0.5, a mini mental status score greater than 22. So these are patients with, MCI, mild AD. And again, the primary endpoint, much like the anti-amyloid drugs, is going to be this CDR sum of boxes score, which looks at their function along all those 6 different memory and other endpoints. And so you can see these patients are going to be treated either with semaglutide, 14 milligrams, and these are not patients that necessarily have diabetes or obesity. So they're trying to see if these drugs have effects independent of their effects on metabolism and obesity. There's 2 trials. EVOKE is general patients. EVOKE Plus are patients that have cerebrovascular disease on MRI. So those patients, there's some thought that maybe they will benefit more because this drug may work to reduce atherosclerosis in the brain and maybe have an effect that way. It's a 156-week trial, so it's quite long and should give some very interesting data. They're looking at a variety of neuroinflammatory markers in spinal fluid and blood, including well-known Alzheimer's biomarkers like YKL-40, soluble TREM2, GFAP, as well as several cytokines, complement proteins that should give a lot of information. They're looking at sort of the more typical Alzheimer's disease biomarkers like amyloid beta 42-40 ratio, p-tau 181, neurodegeneration. So these will tell us about amyloid plaques, neurodegeneration biomarkers like neurofilament light chain, blood-brain barrier biomarkers, oxidative stress. So they are really looking at a variety of things. And so with that, I will leave you. I hope you've gained some information about where we stand in the world of neuroinflammation and how these neuroinflammatory processes affect Alzheimer's disease, and how in the future we hope to be able to target these very specifically to reduce risk of Alzheimer's disease and potentially treat patients with early stage Alzheimer's disease. Thanks for your time.
Thank you for listening. Remember to download the practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novo Nordisk Inc. To access all materials for this activity, visit peerview.com/AFJ860.